Thank you everyone for being with us today. My name is Areti Angeliki Veroniki. I'm a scientist at St. Michael's Hospital in Unity Health Toronto in Canada. And today I'm going to co-present with Ms. Sofia Tsokani, who is a PhD candidate at the University of Ioannina in Greece. And we're going to discuss about the impact of reporting guidelines and the prevalence of inconsistency in systematic reviews with network meta-analysis. Mainly today, we're going to discuss about two publications. The first one, they are recent publications, and the first one was published in the systematic reviews, is about reporting guidelines, to see whether there is an impact in the published network meta-analysis. And the second one was published in the BMC Medical Research Methodology, and it's about assessing the prevalence in published networks of interventions. So before we start, we would like to see your experience with systematic reviews and network meta-analysis. So we'll start with a poll to see whether you have used systematic reviews with network meta-analysis of evidence in decision-making, whether you have conducted or been involved with another systematic review and network meta-analysis, both A and B, or probably you've never used network meta-analysis before. So I see that most of you actually have never used or conducted a systematic review with network meta-analysis. So I'm very happy to actually introduce you to network meta-analysis today, along with my colleague Sofia, and hopefully you'll find this presentation helpful. So let's assume we have a patient with cervical cancer, and this woman actually needs to get treated for CIN. And there are several excisional and ablative techniques. However, this woman actually plans to get pregnant after the treatment, but she worries about preterm birth. There is some evidence in the literature that associate preterm birth with treatment of CIN, but there are also other studies that do not suggest that there is such a relationship. So evidence in the literature can be conflicting. So now the question is which study we should trust and which of these methods is the most safe method to perform. Now, let's assume we have conducted a systematic review and we have identified 8 techniques for cervical cancer, CIN. So these 8 techniques here are depicted with blue circles. And the question now is which of these techniques this woman should actually trust to continue with the treatment. Now, in this systematic review, we identified in total 27 studies. And these 27 studies can be included in 23 different meta-analyses. So you can imagine if we were to conduct 23 different meta-analyses, then this would be a time-consuming task, but also it might not be that efficient. So we need more sophisticated techniques in order to compare all these 8 techniques in a single model, maybe. So what we have presented here is a network plot with all these 27 studies and these 8 techniques, as we discussed before. So each circle represents the different technique, and the weight, the bigger the circle, actually, the more patients that have been involved in these 27 studies. And its edge represents at least one study that compares the interventions that it connects. So we may find studies that compare at least 2 interventions, 3 interventions, or even more. But it's really highly unlikely to find good quality studies that compare all the interventions of interest actually in a single RCT. So the question now is, what is the best available treatment and how we can synthesize all this evidence together in a single model? So a more sophisticated technique is a network meta-analysis, and you can see that since 1999, in this bubble plot here, there's a steep increase in the conduction of systematic reviews and network meta-analysis. And mainly this is because it comprehensively uses all the available data, it avoids selective use of indirect evidence, it compares interventions that haven't been compared in the past, it can increase precision in the estimated treatment effects, but we can also rank all the competing treatments for the same condition regarding their safety or efficacy. And we're going to discuss about each of these advantages in the next few slides. So let's focus on this particular network plot, and particularly in the specific triangle that compares LEDs versus colposcopy versus laser ablation. So we have 10 studies that compare LEDs versus colposcopy. So we may consider, let's say that this is the direct evidence. We have 10 RCTs that compare these two specific techniques. But we also have some indirect evidence through the common comparator that is the laser ablation. So we have another 6 studies that could potentially contribute to informing this treatment comparison, LEDs versus colposcopy. So if we want to, it would be actually good to inform this treatment comparison, combining both direct and indirect evidence into a mixed effect. Now, network meta-analysis, instead of selecting indirect paths in the network, it uses all possible indirect evidence from the remaining network as the indirect evidence. Also, compared to if we compare meta-analysis and network meta-analysis estimates in this plot, you can see that there is in blue the meta-analysis estimates, and in red the network meta-analysis estimates. So you can see that, for example, we have the CKC treatment effect versus colposcopy, RD versus colposcopy, and so on. Now, if we notice a bit more, we can see that CT versus colposcopy was only indirectly compared. We have no studies compare CT versus colposcopy. So one advantage of network meta-analysis is that we can infer on such treatment comparisons that have not been conducted in the past. But also you can see that we gain precision. Since we put all this evidence together into a single model, both direct and indirect evidence, then we are able to gain precision into our results. Another important advantage of this network meta-analysis technique is that we can rank the interventions according to their safety. So here, for example, we use the SUCRA, the surface under the cumulative ranking curve, and we were able to provide a hierarchy of these interventions. So you can see that colposcopy hires as the best. It has a probability of 92% to be among the best interventions. And laser ablation, it has approximately 84% probability to be among the best interventions. However, ranking may change depending on the effect modifiers, depending if we use different outcomes, if we use subgroup or meta-regression analysis. So we have to be aware that when, let's say, here we have combined all evidence together, this colposcopy had 92%. And laser ablation had 84%. But when focusing only on the studies for CIN2 plus above 70%, then this probability actually drops. So there are several plots that we can use to present the ranking. There are the SUCRA plots, we have the Rankine plots, we have Haas plots, we have the Killing plots. So there are several ways to present the ranking of interventions. I'm not going to get into the details of these plots, but it's good to be aware that there are several ways of presenting this hierarchy. So in the pyramid of evidence, we can see that at the bottom we have the observational studies, then we have the randomized controlled trials, and then we have the meta-analysis of RCTs when we focus on 2 interventions. Now, if we're interested in comparing many interventions, then we can move a level further to the network meta-analysis of RCTs. And actually, WHO uses network meta-analysis results to provide the guidelines. However, only a quarter of the NMAs that were published until 2015 were of high methodological quality, and half of the meta-analysis of the network meta-analysis assessed the prerequisite assumptions. And all these reviews actually showed that there were several numerous deficiencies in understanding the assumptions, in using appropriate methods, and using appropriate search strategies. So in 2015, the PRISMA statement was extended to network meta-analysis to provide guidance in reporting, but also to provide indirectly guidance on how to conduct a review with network meta-analysis. So before we move on, we would like to see if in the systematic review that we potentially were involved in, or that you have encountered, you read, what was the reporting that you encountered? Was it the PRISMA with the 27 items? Was it the PRISMA extension for network meta-analysis? Potentially other guidelines, or none of these? So it's, first of all, it's good to hear that 53% have encountered or have used the PRISMA extension for network meta-analysis. We have some responses where the reporting was only using PRISMA, but we have also a good percentage, 32%, that none of these actually were used. So this is something that we need to work on, I guess. Okay. So I'm going to stop here, and Sofia can take from now. Maybe I should mute myself somehow. Sorry about that. Or maybe not. Sofia, you can continue.
Yes, thank you, Areti. So we're going, I'm going to present the article Areti mentioned in the beginning about the reporting guidelines and their impacts. So a little bit, a small introduction to reporting guidelines. So reporting guidelines actually is the minimum list of information that is required in a manuscript. So actually they are checklists. They are checklists of items that are required to be reported in order to have a manuscript that is clear and fully understandable by everyone. So according to the Equator Network, there are several reporting guidelines for the different study types, and for systematic reviews, the recommended one is the PRISMA. So the PRISMA is the checklist, the guidelines for, it is the preferred reporting items for systematic reviews and meta-analysis. So in 2009, PRISMA checklist was published out, and it refers to the systematic reviews of interventions and meta-analysis or any other analysis, but regarding interventions. And it consists of 27 items that actually give guidance on what to be reported in the introduction, the methods, the results, and the discussion sections of an article. Yes. So then the author, after there was an increase in the number of network meta-analysis published here. So in 2015, the PRISMA extension for network meta-analysis was published out. So this extension referred to the systematic reviews that compared multiple treatments and intervention within a network, so conducting network meta-analysis or another indirect comparison. So this checklist, this new checklist, consisted of 32 items, the 27 items of the original PRISMA checklist, adapted, of course, to network meta-analysis, and 5 new items which were NMA specific. So these new items aim to describe the methods used to explore the network geometry or the network plot, and methods used to assess inconsistency and the results of inconsistency. And also these items aim to give a brief overview of the network characteristics. So we had already a database of the network meta-analysis published up until 2015, and we updated that database from April 2015 to July 2018 using the same search strategy and the same eligibility criteria. So in brief, the eligibility criteria were all the included NMAs should include only randomized clinical trials. The network should consist of at least 4 interventions. A valid network meta-analysis method should be used, and the number of studies should be greater than the number of interventions. So since the PRISMA network meta-analysis checklist was published out in June 2015, we thought that it would be a good idea to compare what happened before and after the publication of PRISMA-NMA checklist. So we concentrated on articles published between 2013 and 2018 in order to compare these time periods before and after, and how the PRISMA network meta-analysis checklist affected the reporting. So we did a little, for all these articles we concentrated, we did a little data extraction. Using a predefined form in REDCap, we extracted the publication characteristics such as the country, the journal, if the journal endorsed for PRISMA or not, publication year, impact factor, funding details, and risk of bias details. We extracted also characteristics of the network. So, for example, the type of interventions, were they pharmacological or not pharmacological. We extracted the network plots details. For example, if there was at least one closed loop in the network. We extracted the methods used and the inconsistency methods used, inconsistency assessment and results. Then we need to find out a way to note down the reporting of each article. So we considered that each item is a checkbox. And if the checklist item is reported, then we just tick the checkbox, otherwise we did not. So in this way, we created the PRISMA scores. So we assigned each article a point if the item was reported, and 0 points if the item was not reported. So then an article that had everything reported, all items reported, would have 32 points. So the excellence score would be 32 points. But then we noticed that some items may be complex. For example, this item, the first item of PRISMA checklist. And we considered that it would be better to split these items into more items in order to have a more detailed version of the PRISMA. So the original PRISMA-NMA score refers to 32 items of 30 points, and the modified PRISMA-NMA score refers to 49 points after splitting the complex items into more items, and we have 49 points. Also, we grouped all the 5 new NMA specific items, and created the NMA score of 5 points. So in general, we found that across the whole database, that all the articles were published out in 450 different journals. 33 of them had endorsed for PRISMA, and the most popular journals was the PLOS One, the Oncotarget, and Medicine. Only 3% of the collected networks were published in Cochrane reviews, and the median impact factor was around 3.7. So and then we found out that the majority of the published network meta-analysis didn't have a protocol, and most of the networks included mostly pharmacological treatments. And this is a distribution of the collected network meta-analysis around the world. We see that China is publishing out a lot. The first collected, the most network meta-analysis were published out in China. And then comes the United States, then comes the United Kingdom, and then comes Canada. So our aim was to explore the impact of PRISMA network meta-analysis according to the publication year, the existence of protocol, the PRISMA endorsement, the impact factor, funding details, and the treatment type details. And we used the modified PRISMA-NMA score for this in order to have more detailed and detect the deficiencies, the reporting deficiencies. So we see that the mean score across all the networks, the mean modified PRISMA-NMA score was 32.1 points, which is adequate, but it's still not high if someone considers that the best score would be 49 points. So then we considered the year. We considered 2015 because in 2015 was the modified PRISMA-NMA score was published out. So we see that after 2015, the reporting is slightly better. After 2015, the mean score is 32.6, while before 2015, it's 31.3. It's better, but only slightly. So that's a big difference. And over the years, we see that there is a tendency for the average score to improve. But we also noticed that while in 2016 the average score is 33, it becomes less in 2017, and that was a paradox for us too, because as the years passed in 2017, we have the more of the articles published in 2017, and we consider that maybe it would become better. But we tried to shed some light on this and actually found that the articles in 2015 were published out in lower impact factor, in journals which had lower impact factor. So perhaps that would be a reason for this decrease. So we can see here that the network meta-analysis that were non-sponsored or publicly sponsored or sponsored was not reported actually did better regarding the reporting rather than network meta-analysis that were funded by industry or had mixed funding. And the same happened for network meta-analysis that had a protocol. They did better rather than articles, network meta-analysis that did not have any registered protocol. So in order to better explore all these associations, we conducted both univariable and multivariable analysis. And in the univariable analysis, we treated the year as the cotempo variable, so before and after 2015. And we find that after 2015, the PRISMA score increased by 1.25 points after the publication of the PRISMA-NMA statement. So then we performed some groups to find, and we found that the average increase in the score per year before 2015 was 0.96, while after 2015 was 0.53. So this shows that there is an improvement both before and after 2015, so both before and after the publication of PRISMA-NMA, but the speed of improvement is better before. There is still improvement after 2015, but the improvement is much more slower. So this so this happens maybe due to the fact that before 2015 or up until 2015, there were other guidelines like the ISPOR or the NICE guidelines, and authors advised of all these guidelines that were published in order to improve the reporting. So, of course, after 2015 there is improvement, but we can say that up until 2015 they were already trained. They kept already trained for good reporting, so they kept training after the publication of PRISMA-NMA, but it becomes more slower. So then the multivariable analysis, there was an average increase in the score per year, 0.181 points. And also there was an increase in the score if the network meta-analysis was non-sponsored or publicly sponsored, and as the impact factor increased, also the reporting increased. However, there was a decrease in the score if the protocol did not exist, and actually by 5 points. And also there was an average decrease in the score if the network included pharmacological treatments. So in general, 49% of the items improved and 47% of the items deteriorated. But since the PRISMA network meta-analysis was published out for network meta-analysis, we see that actually the NMA-specific items did improve. Not that much, there's still room for improvement, but they did improve. For example, we see that for inconsistency, which is a major assumption of network meta-analysis, there is still room for improvement, but these items improved over the years. So we're going back to Arjen.
Okay. Thank you, Sofia. So the next paper that we're going to discuss is about the prevalence of inconsistency and its association with the network characteristics. So before I get into the details of the paper, we have, as Sofia said, we have to always consider whether a network meta-analysis is valid. And when we put together direct and indirect evidence into a single model of network meta-analysis, we should always ask ourselves whether the results make sense, whether they are valid. And we always need to remember to evaluate the prerequisite assumptions. So on top of what we consider for standard meta-analysis, that is homogeneity, in a network meta-analysis model, we have to consider about the transitivity and consistency assumptions. So transitivity actually is the clinical and methodological homogeneity of treatment comparisons within a network, whereas the statistical manifestation of transitivity is consistency. So transitivity is not, there's no statistical way to assess for transitivity. We can only, let's say, use plots and compare the average treatment effect modifiers across the treatment comparisons in the network. But statistically, we can use methods to assess for the consistency assumption. Now, let me tell you a few details about the transitivity assumption and the indirect comparison. So let's consider that we have the 4 Daltons and we are interested in comparing them regarding their height. So let's say that we have Joy's height and William's height. So we are able to calculate the difference between William and Joy. So if we also know the height of Avril, then we can also calculate the difference between him and Joy. So if we're able to calculate the 2 differences, and from these 2 differences, we can calculate the difference between Avril and William. So this is the notion of indirect comparison. And when we use heights and specific people, then that's easy to do. But when we move to studies that we include entire populations and studies with different characteristics, then this become a little bit more complicated. So let's say now that we have some studies that compare A versus B, and we have some studies that compare treatments B versus C. So the treatment B is the common comparator in both sets of studies. And since we have a common comparator, then we're able to calculate the indirect comparison for A versus C. Now, in a network meta-analysis, when we have both indirect evidence and direct evidence, then as we said before, we can combine them into a mixed effect and we can obtain a mixed evidence. However, for the indirect comparison, so as to make sure that it's valid, we have to assess for the potential effect modifiers. So let's say that AIDS is an effect modifier. And in this open triangular loop, we have some studies for the A-B comparison and these studies actually have on average participants that are around 50 years of age. Whereas the BC studies include participants around 20 years of age. So in that case, the indirect comparison, if age is an effect modifier, then this indirect comparison would be invalid. However, on average, if these studies, the AB studies and the BC studies included participants more or less of the same age, then this would be a valid indirect comparison. And of course, we don't expect these distributions to be exactly the same. We expect them on average to be similar. So regarding now how this translates to consistency, when the common comparator of the loop is transitive, then the indirect comparison between the 2 treatments is valid. So when we move to the consistency assumption, then we expect that this indirect comparison that we calculated and the direct evidence are in agreement. So consistency is actually a property of closed loops. And there are several approaches to assess for inconsistency. We have approaches to assess local inconsistency in particular paths of the network, but we also have methods to assess global inconsistency in total, entirely in the network. I'm not going to get into these details, but I just want to inform you that there are multiple approaches to assess for the consistency assumption. So before I move on to the paper, I would like to see your experience and the method that you used to assess for inconsistency, whether you used global inconsistency methods, local inconsistency methods, maybe not statistical methods at all, or you did not assess for inconsistency, or this was not applicable in your case. So I see that most of you have used or have encountered NMAs that have used local inconsistency methods, but also 18% have also used the global inconsistency statistical approaches. Some have not assessed inconsistency, and for some this was not applicable. Maybe they didn't conduct a network analysis, or they didn't have a closed loop in their network meta-analysis. Okay, so let's move on. There. So let's see what empirical evidence suggests so far regarding network meta-analysis. So in recent years, the majority of published network meta-analysis assess the prerequisite assumption, which is an encouraging point. However, there are some reviews that still combine direct and indirect evidence without assessing for consistency or despite the evidence of inconsistency. And this is something that we need to resolve. Also, empirical findings suggest that 1 in 10 loops of evidence and 1 in 8 networks are inconsistent. So in our previous review, we found that the network meta-analysis authors increasingly discuss the assumptions of transitivity and inconsistency compared to the past, compared to 2005, let's say, and more frequently now use appropriate methods to assess for inconsistency. But also we have to consider always that there is a relation between heterogeneity and inconsistency. So an increased amount of heterogeneity might be associated with lower detection of inconsistency rates. And the other thing that we always have to keep in mind is that inconsistency tests are of low power. So we may not be always able to detect inconsistency. And in order to try to explain how heterogeneity and inconsistency are related, so you can say whenever we have heterogeneity in our direct and indirect evidence in our network, then the confidence intervals become wider. So in that case, we are not able to detect the prevalence of inconsistency. And also the other consideration that we should always make is that the heterogeneity estimator, the choice of the heterogeneity estimator may influence the results of inconsistency because they are associated with different properties. So the aims of this project were mainly to estimate the percentage of network meta-analysis for which evidence against the hypothesis of consistency is evident, to describe the association between inconsistency and network meta-analysis characteristics, but also evaluate heterogeneity in both consistency and inconsistency models. So all these aims are related together, and then we attempted to explore these. Now, in our methods, we performed both consistency and inconsistency models. And in both models, we used 2 different heterogeneity estimators, the Simon and the restricted maximum likelihood. And for the inconsistency model, we used the design by treatment interaction model, where we evaluated the joint significance of all these inconsistency factors that can be located in a network. And we used the chi-square test. Now, we also used, we assessed the evidence of inconsistency using a p-value, the DBT test, the design by treatment interaction test. So we used the 5%, the commonly used 5% cutoff value, but also we used the 10% since so far evidence has shown that inconsistency tests may be of low power, but we also found that the 10% of the loops in empirically were inconsistent. Now, we updated our previous empirical database, as Sofia described earlier, from 2015 up to July 2018. And this was a collaborative effort through St. Michael's Hospital and the knowledge translation team, the University of Ioannina and the evidence synthesis methods team, the University of Bern and the University of Paris. And in this particularly database for the inconsistency assessment, we included data, network meta-analysis with dichotomous data, network meta-analysis that include at least one closed loop so as to be able to assess for inconsistency, and also network meta-analysis that's with available data, because not all of the NMAs that are published provide their data. So we ended up with 201 NMAs. Now, in these networks, in these NMAs, actually, we found that the median number of studies per network was 20. The median number of interventions per network was 7. We had the 70%, the majority of the networks with multi-arm studies. The median number of multi-arm studies in these networks was 1. And the median number of direct comparisons were 10, and the median number of loops was 3. So now that we're a bit familiar with the database, as we said before, we performed both De Simone and Laird and restricted maximum likelihood estimators. And we used as the reference standard the restricted maximum likelihood estimator for heterogeneity. So because this is the most appropriate method that has been suggested according to empirical evidence so far and simulation studies. We can say that most networks were statistically consistent, since we were able to detect inconsistency in 14% of the networks using the restricted maximum likelihood and the cutoff value of 5%. And if we also have a look at the distribution of inconsistency rates, we can see that there is no important change in the prevalence of inconsistency across the years since 2000 up to 2018. Now, we also assessed some network meta-analysis factors, including the number of studies, the number of interventions, the number of loops, the number of designs or treatment comparisons, and we found that most factors did not greatly influence the p-value of the inconsistency test. But we found weak associations with the p-values, where we found that the dense networks that included more studies and fewer treatments, were weakly associated with smaller p-values, that is higher detection of inconsistencies. So this was most probably because they yield more precise estimates. We have shorter confidence intervals since we have more information for each treatment comparison, and that's potentially that's why we found inconsistency more frequently. Also, we found that the inconsistency models displayed higher heterogeneity, accounting probably for inconsistency in the data. And as you can see here, we compare the between study heterogeneity in the consistency versus the inconsistency model. Again, before we move on, I would like to assess, to get your experience with systematic reviews, with your systematic reviews and network analysis, whether you encountered inconsistency and what you did, whether you explored this further, you decided not to synthesize the data, you did not explore this, or there was no evidence of inconsistency, or maybe this was not applicable again. So this is great news that most of you actually, when you found inconsistency, you explored this further using network meta-regression and subgroup analysis. So some of you did not find any inconsistency at all, or this was not applicable, and the 18% did not explore this further. So this is something that we, again, would need to work on. So what we do, let's see, what we do when we find inconsistency in our data. So the first what we usually do is to check the data, first of all. Maybe we have conducted data abstraction errors, similar to the considerations that we make when we conduct a standard meta-analysis and we find high heterogeneity. So we start with the data to see if the data are correct, it makes sense. And once this is confirmed, then we may go potentially synthesizing the direct and indirect evidence into a single model. We may want to present them separately, or we may want to explore this further using subgroup analysis and network meta-regression analysis, as some of you did. Or another option would be to introduce this inconsistency into the results. So use models that we can relax the consistency assumption. Okay, so in summary, what we found is that evidence of inconsistency was more frequent than what we would expect if all the networks were consistent, although the rates were low. So still, this suggests that inconsistency, when it's found, it should always be explored. Detection of inconsistency was mildly sensitive to the network characteristics, as we said, regarding the number of studies and the number of interventions. Inconsistency was likely to manifest as extra heterogeneity when the consistency model was performed and in the presence, as we said before, inconsistency. And overall, there was a good agreement between the different heterogeneity estimators. And regarding reporting, we, as Sofia said, we updated the PRISMA-NMA to the 49 items to make this easier to assess, and potentially that would be easier for the author as well, for the authors of the NMAs. And what we suggest actually is that the PRISMA-NMA is endorsed by more journals than what is already being done. At this point, we would like to acknowledge all of our co-authors of both papers. And thank you for your time and interest into this presentation. And of course, we're happy to take any questions for now.
Great, thank you so much, RG and Sofia. So, so please, if you have questions, can you either put up your hand or type them in the chat? But we do have one question from, oh, actually, before we go into questions, maybe we should just do our poll first. So we have one last poll, which will only take a minute. So maybe we can go into that. And in the meantime, can you please type your questions in the chat?
So I launched the evaluation poll, and I will leave it up there for the rest of the session. So at your leisure, there are 5 very simple questions. You have to answer all of them and then click submit, and we'll leave this up for the remainder.
Okay, wonderful. Thanks, Ciprian. So we have a question from Allison Gates, who asks, are you aware of or can you recommend strategies that may help improve the uptake of and adherence to published reporting guidelines?
That's a very good question. I don't know, Sofia, if you want me to take the question or you would like to discuss to start.
Whatever you like. Some strategies. I can take it. I think that when the authors are writing, are reporting the results of network meta-analysis, to stick to the guides that the PRISMA network meta-analysis extension gives. So this is actually a checklist. I said that I think it's a very good guide for someone to report the right things to the right section. So I would recommend someone just to read it, taking advice of the PRISMA-NMA extension when the author is writing down his results of the network meta-analysis, and this will save time, of course, and also it will lead to the right path. You will find what you have done or what you would have not done so far before going on with the publication.
Exactly, I would agree. So the PRISMA-NMA guidelines, I believe, are very helpful to improve reporting in network meta-analysis. So what we've noticed in this project is that not always these PRISMA guidelines were not followed. And mainly this was because the journals did not endorse these guidelines. So we need more journals to endorse the guidelines to improve the reporting of NMAs.
Great, thank you. We don't have any more questions, but I have a question. So, based on this research that you've done now, you've said there's a few problems. What future research are you planning?
On the reporting, you mean, Carol, or the inconsistency?
Well, both actually, because reporting especially, I mean, there's definitely, journals that don't endorse PRISMA-NMA right now, and that needs to change.
Exactly. Absolutely. I totally agree. So we need to change that. We need to suggest, we need to, as we said, to have journals that endorse these guidelines, but we also need more NMAs with proper protocols. As Sofia showed, there were many NMAs that actually did not conduct a protocol, not published protocols, but even citing a protocol that is in a registry, or is it uploaded somewhere in their website. So if a protocol was pre-conducted before, the network meta-analysis to be conducted, we found that these NMAs were much better than in reporting and in the conduct actually than the others. So this is something again to consider, certainly.
Definitely, that sounds great. All right.